And I can't stress enough how often I get questions about, is this the paclitaxel doing this? Is this the docetaxel doing this? And coming up with strategies to kind of help get our patients through with supportive care is important. It's a really big opportunity for pharmacists and our nurses to really provide and help our patients get through and show the knowledge that we have and to help them.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Dane Fritzsche, Oncology Informatics Pharmacist at the Fred Hutchinson Cancer Center in Seattle, Washington, about plant alkaloids. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Dane.
Thanks. Happy to be here, Jamie.
So we'll start at the beginning. Can you explain to our listeners what is an alkaloid?
An alkaloid is an organic compound. So think carbon-based ring structure. The only thing special about an alkaloid is that it has to contain at least one nitrogen atom.
All right. So we've got a little bit of the background from a chemistry perspective. So let's talk in more depth about just a brief overview of the history of plant alkaloids in the field of oncology.
Yeah, so I'll kind of dive into the next step of plant alkaloids. So when you think of the alkaloid, we kind of just defined that. And then plant alkaloids are just alkaloids derived from plants itself. So think like the roots, stems, leaves, bark, and things like that. Each of these agents we'll discuss today are unique, but broadly speaking, all of them are extracted, at least when they are first discovered, from a plant source. And they are typically biosynthesized by these plants for defensive purposes. Most cases these days, though, the product or the chemical compound itself is no longer harvested from the plants owing to poor yields and scalability. So most now are synthesized in a lab. In terms of its history in the use of oncology, plant alkaloids had their first kind of notable discovery back in the early 1950s. Charles Beer and Robert Noble were examining Vinca rosea, and they were originally examining this actually for a hyperglycemic effect, but then they noticed some effects on bone marrow when they were studying these compounds in rats. And further study led to the isolation and characterization of vinblastine, one of the first plant alkaloids that we'll talk about. One other one that I wanted to dive into just because it's interesting is paclitaxel. Paclitaxel is probably the most successful and widely used plant alkaloid that we'll discuss today. It was isolated from the bark of the Pacific yew tree.
I'm very familiar with paclitaxel. That was my bread and butter when I was in direct clinical care. So I'm interested to hear more in depth about kind of how that drug works today. So let's talk about that. What is the mechanism of action of plant alkaloids?
Broadly speaking, they are cell cycle specific agents. They do, depending on the compound, impact different parts of the cell cycle. Topoisomerase inhibitors is an example. So think irinotecan, which is a topoisomerase 1 inhibitor. There's topoisomerase 2 inhibitors, like etoposide being a good example. These impact the S phase in your cell cycle, so the synthesis of the DNA. Topoisomerase kind of helps unwind DNA and stabilize that as it's being replicated. And then the other broad kind of mechanism of action that is also cell cycle specific is your microtubule inhibitors and stabilizers. So you can think they're your vinca alkaloids like vincristine, vinblastine, which we just mentioned, or your taxanes like paclitaxel and docetaxel.
Great. We've mentioned some drug names, but let's talk about that a little bit in more depth. What are some of the primary subclasses of plant alkaloids, and maybe highlight some examples of the most common agents in those subclasses are?
So the subclasses kind of break down based on their mechanism of action. So your topoisomerase 1 inhibitors like irinotecan, the liposomal formulation, or topotecan is another example. Topoisomerase 2 inhibitors, the other one here, the big one, etoposide or vepsid-16. Taxanes, paclitaxel, or nab-paclitaxel, the albumin-bound formulation, docetaxel, and cabazitaxel. And then your vinca alkaloids, which is vincristine liposomal formulation, vinblastine, and vinorelbine are kind of your big heavy hitting agents that are most commonly used.
Those are definitely names that have been around a while in the world of oncology, most of them. So those should all ring familiar for, I would say, a lot of our listeners. What are some of the common toxicities or adverse events that are associated with plant alkaloids, both as individual agents or more broadly as subclasses?
So I think what I'll do is I'll kind of start from the beginning. Again, these plant alkaloids kind of fall into your typical chemotherapy side effects. So we're thinking rapidly dividing cells, our bone marrow. So is it lowering our red blood cells, our white blood cells, our platelets? And then it can also affect our GI tract, whether it causes diarrhea in some cases. In some other cases, it can actually cause the other way and cause severe constipation. And then a lot of these agents do lead to hair loss. So that's kind of the first big category of side effects that we think about. All of these agents will have these side effects to varying degrees. And then as we get more into our classes and agent-specific ones, we can find more interesting side effects or more specific ones. I think what I'll do is I'll start with just from the top here at topoisomerase 1 inhibitors and just kind of select irinotecan as our poster child for that. Irinotecan side effects, so I really think of it as being toxic to the bone marrow. First of all, like we already mentioned, it can lower our white blood cell counts, and depending on the dosing, we may want to think about supporting that with GCSF or other supportive measures. One of the more unique side effects that irinotecan has is diarrhea. So there's two types of diarrhea it can cause, both acute, which is within the first 24 hours, and then more of a delayed onset diarrhea, which is after 24 hours. The acute onset diarrhea is thought to be as a result of its cholinergic properties. So we actually have a pre-medication to help prevent this using atropine. And sometimes if the diarrhea does set in or the patient's starting to feel that crampy, bloaty feeling, they're asked to speak up, and we might give a second dose of that atropine just to help fight that off. Jumping into a topoisomerase 2 inhibitors or etoposide or Vepsid, this agent is really kind of your classic chemotherapy that I think about. So I don't think a lot of unique side effects, except one that I still remember when I was going through residency that just kind of surprised me, is because of its high alcohol content when you're using really high doses. So think for our patients who are undergoing bone marrow transplant, they can actually get a little bit tipsy while they're getting this medication because there is so much alcohol to help keep it in solution.
Wow.
Yeah. Moving on to taxanes. And this one is where we might slow down just a little bit because there's a lot of different unique side effects. Paclitaxel being the big poster child that I think we'll talk about. Here, first, I really think about the hypersensitivity reaction, which is most commonly seen in the first 1 or 2 dosings. However, it can come out really at any point in time. Lots of pre-medications, especially with the first formulation of paclitaxel, is used to help prevent that. We're using antihistamine, so think your Benadryl. We're using our H2 receptor antagonist, so end up hitting histamine again with famotidine. And then we're also using corticosteroids to help prevent this. One thing that I always like to point out, kind of thinking from my nerdy pharmacy brain, is it's not actually being allergic to paclitaxel, but it's more of the solvent that helps keep the paclitaxel in solution because it is actually poorly soluble to begin with. And the agent used in paclitaxel is cremophore. So patients are not actually generally reacting to paclitaxel. They're reacting to the cremophore in it. And what's nice is if this does happen, sometimes we might switch formulations to that nab-paclitaxel, which does not require that cremophore agent. And we see a lot less hypersensitivity reactions with this agent. Other side effects with this one, paclitaxel, I almost uniformly expect patients to lose their hair. So that is one of the more difficult conversations I've had with patients when I know they're getting paclitaxel, say for breast cancer is a good example. I just kind of help them set that expectation. It's a tough conversation, but yes, you will lose your hair with this. There are strategies to help prevent it or mitigate it, such as using cold cap. But it is kind of an inevitability, especially if patients are getting multiple cycles of the agent. The last thing I wanted to touch on with paclitaxel is neuropathy, or your pins and needles tingling in the tips of your hands and toes. That is the most common one. So that's a sensory neuropathy. But we also can see motor neuropathies with this agent, where the patients start to struggle with their fine motor skills, like buttoning shirts, using pencils, things like that. This is a cumulative dose effect with paclitaxel. So if patients are on multiple cycles, we definitely start to ask, how that's going. We expect at some point this is going to become an issue as therapy continues. Next, jumping to its cousin, docetaxel. This one's more commonly used in prostate cancer, though it is included in breast cancer regimens as well as thoracic, head and neck cancers, as well as some GI cancers. This agent can also have that hypersensitivity reaction in the first 1 or 2 cycles, but it is a lot less common. And that's because its solubilizing agent, which is polysorbate 80, we don't react to as often. So I really think of this agent as more of a dose-limiting toxicity being bone marrow suppression, hitting our platelets, hitting our white blood cells. One of the newer agents in this class is cabazitaxel. This one is approved in hormone refractory metastatic prostate cancer. It similarly can have that hypersensitivity reaction we've talked to and does require pre-medication. The doses do vary a little bit, so I would encourage our listeners that if they're interested in that nuance to pull up a package insert, it's only a smaller dose of the corticosteroid. But again, this one, I think of more of myelosuppression, and then neuropathy can also occur.
Absolutely. And I think as we move on later in the episode, we'll talk specifically about some of the patient education points around the taxanes that are important to emphasize. But thank you. That's a great summary of those side effects that I think are pretty common for our nurses to experience, since this class of agents is given so very often.
It's used all over the place, and I can't stress enough how often I get questions about, is this the paclitaxel doing this? Is this the docetaxel doing this? And coming up with strategies to kind of help get our patients through with supportive care is important. It's a really big opportunity for pharmacists and our nurses to really provide and help patients get through and show the knowledge that we have and to help them. The last class we are going to touch on for more agent specifics is our vinca alkaloids. I think the biggest takeaway, and something that was just kind of hammered into my brain during residency and during pharmacy school, is that these agents should never be in a syringe. And that's because they are fatal if they're accidentally given intrathecally. Unfortunately, this has happened before in the past, owing to a lot of these agents being used in regimens that also have intrathecal medications being administered, and just an easy swap. And it's very unfortunate. So those should always be in an IV bag, even though they can be administered quite quickly if you just want to be extra careful. And then the other kind of big thing with vinca alkaloids, just as a broad category, is these agents are vesicants. So monitoring for extravasation is important. For the more agent-specific considerations, I think of a lot of these as mostly just having our bone marrow toxicity. Vinblastine, I remember the B in vinblastine. I think bone marrow, B for bone marrow. And then vincristine, I think of C for constipation. So this one can cause a paralytic ileus, and it can be severe. I've only seen it once. I had one patient in the hospital who did develop this, and it was weeks of issues. Other issues with vincristine is neurotoxicity. So we're also asking about, are you noticing any neuropathies or other confusion, stuff like that, motor weakness? And then finally, vinorelbine. This one is most commonly used in metastatic breast cancer and lung cancer. It has similar side effects to kind of both of them above. So you still can hit the bone marrow, and it also can cause our neurotoxicities.
Well, thank you for giving that quick but comprehensive review of some of those typical side effects for those classes and individual agents. I think, as I said, these are ones that I have been around for quite a while, and I think our nurses have seen and are familiar with those. So it's still great to get that overview for maybe some of our listeners who are newer to the practice. So let's move on now to some of the ways that we can help to manage or help control some of those toxicities that you just mentioned. What are some of the pharmacologic kind of related strategies that can be used when dealing with those types of toxicities that we just ran through?
Yeah. So like say with irinotecan, and we have that diarrhea as kind of being the big issue that I think about. Pharmacologically speaking, kind of the first question you have to ask yourself is, when is this happening to relation when the medication was administered? If this is happening during the administration or shortly thereafter, we're really leaning on anticholinergic medications like atropine. So a second dose of that would be really helpful. However, if a patient's calling us a day or two later after getting this medication and they're having diarrhea, this is more going down our typical chemotherapy-induced diarrhea pathway. And really the big one that I start with is loperamide. Patients should hopefully have that or be able to get it easily since it is over the counter, and really just starting from OTC instructions. So they should take 2 tablets at the sign of first onset of diarrhea and then 1 tablet at each episode after that. But from there, if they're still having issues, we might be a little more aggressive with our dosing and recommend kind of around the clock dosing. If the diarrhea is still getting worse or patients are having issues with staying well hydrated and getting enough nutrition, that's where we might add on other agents like Lomotil just to kind of help basically stop them up as much as possible and then get that diarrhea under control. And then we can kind of step back in a stepwise approach until we find a happy middle ground, hopefully at the end coming off of both of those antidiarrheals.
Absolutely. And I think for that one, it's important to provide that, reassurance to patients that, yes, it's over the counter. Yes, there's specific instructions on the box, but those are for people with other run-of-the-mill diarrhea. This is not the reason you're being given it. And so the way that we instruct you to take it will be likely very different than what that box says. So, I always try to provide that reassurance that, yes, it sounds like we're giving you the wrong instruction, but for your situation, it's absolutely the right way.
Totally. We always start with those box instructions, but we quickly will surpass that recommended maximum. I've given very heavy doses of loperamide just to get stuff under control.
Absolutely. And I think that's another, and again, I don't want to jump too far ahead, but that's an important education point of that. We're not talking just a mild inconvenient diarrhea. This could be fatal if we don't control it. It truly can get that severe. So I think just providing that context and kind of that frame of mind for patients to understand, we're not trying to panic, but we want them to understand that it is really important for them to communicate those side effects to us immediately so that we can then jump in and give these agents as soon as possible and keep things controlled.
Yep, exactly. We want to get on top of the diarrhea as soon as it's setting in, just so we, are getting ahead of the possible complications like you were mentioning that could lead to hospitalization and in some rare cases be fatal. Some of the next side effects that we talk about for pharmacologic, I think what I'll move on to is more neuropathy, which we can see with a lot of these agents like paclitaxel, cabazitaxel, docetaxel, and into the vinca alkaloids. Neuropathy-wise is challenging, and it's something that throughout my whole career with patient care, it constantly comes up. And there's really no one great solution to it. There's many different guidelines out there and papers out there that recommend some stepwise approaches. At the end of the day, too, we have to think about what are our goals with our patients? How much is this limiting? And a lot of these agents, the neuropathy continues to get worse if we continue treating with the same doses and continue treating the cancer. With patients who have metastatic disease and we're keeping their disease under control with, say, paclitaxel on kind of an ongoing basis, that's going to be really when we start hearing that neuropathy is a concern for the patient. The first thing that we're discussing with the providers is we should probably dose reduce at this point because it is a cumulative dose effect. We don't expect it to get better if we're continuing to give the medicine. Conversely, though, it is also something that we talk about with our patients who aren't undergoing therapy for metastatic disease, and maybe they have a defined treatment duration. We do expect that neuropathy to improve as time goes on since their last dose. It's up to 80% or so of patients will have full recovery. Unfortunately, there is still that 20% of patients who the neuropathy should at least improve, but it does not go back to pre-baseline. That's where we're looking at using agents like gabapentin. Duloxetine has some data for use in chemotherapy-induced neuropathy. There are a few other agents. It kind of depends a little bit on what their primary complaint is, but those are some of our first go-tos.
I always found that conversation around neuropathy, especially as you mentioned in the setting where it's, first line or curative intent type therapy, where you have to communicate with your patients that we need you to be honest with us if you're experiencing this. Don't hide this symptom, because often patients will kind of keep that to themselves. It's not life-threatening to them, so they're not going to mention it because they want to get their full dose and they want to get through all of their cycles. But again, that's at the risk of potentially having severe, long-standing, potentially permanent neuropathy that persists into that survivorship period. And so that is a conversation, continual discussion of encouraging them to be forthright with how they're experiencing that symptom and just explaining that we have to adjust the dose that's right for them. And so that can always be a challenge, because I understand patients want to feel like they're getting the best, fullest dose and treatment that they can, but we just have to encourage them to communicate with us.
Exactly. It's that benefit and risk calculation that we want to know. What are all the risks that we're giving our patients when we're giving this curative intent? And if they're not honest with us, it's tough to make that calculation accurate. Moving on to maybe going back to the hypersensitive reactions and infusion reactions with the taxanes. So we kind of already mentioned briefly about the pre-medication. So you think a lot of antihistamines, so your Benadryl, your famotidine, and corticosteroids like dexamethasone. But what happens when these things do happen, and how severe can they be? So these hypersensitivity reactions can be very severe, including up to fatal. I've had patients where they've required chest compressions and epinephrine to get them back. Thankfully, that is not the routine nor expected. Most patients might complain of some lower back pain. They might have some stomach cramping. They might have a little bit of flushing in their face, trouble breathing. The side effects can really range from patient to patient. So we always, when patients are starting therapy on, say, paclitaxel, for example, that's something that we mentioned, like, please communicate with your infusion nurse while you're getting this medicine. Symptoms can start as early as immediately after starting the medication, all the way to your 5 minutes from completing the entire dose. And then what do we do when this happens? So as long as it's mild, we will stop the infusion, see how things are going, and we may give another dose of Benadryl, for example, or another round of famotidine, and start at a slower rate when we reinitiate and get you through the rest of that medication. Sometimes if the reaction is a little more severe, we may decide, it wasn't worth restarting here. We're going to come at this with a totally different approach, maybe give some more corticosteroids in the hours up to before starting the medication, and then also going through a slower rate titration all the way up. So the infusion might take a little bit longer. And then sometimes, like with paclitaxel, for example, we may just opt to switch to the nab-paclitaxel formulation, which has a lot less risk of having this infusion-based reaction. You may wonder, like, why don't we just give nab-paclitaxel to everyone? I have had that question asked. Most of the time, this is a little bit payer-driven. Paclitaxel is quite a bit more expensive, so payers do require the generic formulation of paclitaxel to be tried and failed before switching to that one.
Yeah, I think that conversation with patients, just giving them that awareness of the hypersensitivity reaction, it's a little bit of a delicate dance, right? You don't want to freak them out. You don't want to make them panic because they're already nervous. It's probably their first dose or second dose. And so it's a balancing act of making them very aware of like what they should watch for and sensations that they're feeling and letting us know. And then I think communicating that, we have a process to handle these. Like, they are somewhat common. We know what to expect when it happens. And so just trying to calmly reassure them that it's a possibility and that we are equipped and ready to handle it, even though if, like for me, deep down, I was always terrified because I don't respond well to those types of situations. So I was always still secretly deeply terrified, but I did not try to convey that to my patients because, we want them to feel comfortable and safe in our care. And having that team, whether you're, of course, with pharmacy and nurses that are there close into the infusion center, or if you have like a rapid response team, or hopefully not needed, but potentially a code team, just having all of those resources available and knowing what your process is so that when those hypersensitivity reactions occur, the steps to take to keep things calm and keep that patient reassured that they're going to be okay. We're going to take great care of them.
Exactly. Unfortunately, these hypersensitive reactions are somewhat routine because we have lots of patients getting these medications and they're not uncommon, like you said. It's really just that team-based approach. And we since they are routine, we're all pretty comfortable at handling these. But you're correct. It is a delicate dance, making sure that they're aware of the risks of the medication, but also not trying to scare them into not accepting the therapy. I'm trying to think if there was any other big ones that I wanted to talk about other than going into, I guess the last one we haven't talked about was constipation, since vincristine can cause constipation. And in general, it's pretty similar to the management of diarrhea, just kind of the opposite way. So we might give some agents to help keep things moving along. Generally, I start with what I would call our gentle laxative, things like Senna or Miralax, and then we kind of get a little bit more aggressive from there, moving all the way up into magnesium citrate, for example. If we suspect paralytic ileus, however, we don't want to give bulk forming agents or anything like that because we want to make sure things are moving before we're helping with that, or that can cause other very serious issues. So thinking back when I was in residency and had one patient who we think developed this, it was kind of a slow waiting process, waiting for the colon wake back up, for example.
Well, I think that was a great overview, I think, of some of those typical side effects that we see and how we are routinely trying to manage them or, minimize the impact of them. So I think that's been a great overview. Let's talk a little bit about just more of the general administration considerations that nurses should keep in mind when they're administering these plant alkaloids to their patients.
Yeah, that's a good one. Kind of the big thing with these agents is there are, like I mentioned with the vinca alkaloids, they are vesicants. So monitoring for extravasation. This is also important with your taxanes. They can be irritants. So again, most sites that are administering these do have their extravasation protocols and what to do depending on the agent. So I would just make sure that our nurses who are administering these are familiar with these practices, how to monitor for that and all of that. And then I think going back to like our taxanes, especially paclitaxel, there are rate titrations. Some centers have kind of a built-in rate titration that they will follow up front. My center is not one of those. We kind of start at our normal rate, and we do implement a rate titration if patients have a reaction with the first administration.
And again, we've touched on this a little bit already, but let's focus in on some of those primary sort of pearls or patient education points that we want to ensure we communicate to both patients and their family or caregivers if they are receiving a plant alkaloid. And that can be education during the actual infusion or what to consider when they go home and helping them to manage some of those side effects that we've talked about.
Starting with, let's go back to our topoisomerase inhibitors. These agents, sometimes you'll see them given with upfront growth factor prophylaxis. So just kind of starting with the top of our patients, I mentioned you may be at a higher risk of having infections, for example. And what does that mean for them? Are we implementing full neutropenic precautions? Probably not, but we are recommending, staying away from sick contacts, good hand hygiene, things like that. When I'm discussing with patients about the diarrhea that can happen, I do try and be very specific with how we're looking for during the infusion, all the way up to the first 24 hours, and then delineating that from when they should call us and tell us about the delayed onset diarrhea. And what should they do if this is happening, right? Not only talking about the medications that we might send them or ask them to take, but also what kind of foods are we avoiding to help prevent the diarrhea from getting worse? Things like avoiding spicy foods, stuff that is easy on the stomach if they're having nausea, for example, like the brat diet. So trying to pull in not just my pharmacologic knowledge, but also some of the other non-pharmacologic supportive care recommendations for these patients. Other things that I think about with our taxanes is having the more challenging conversation, especially like I did a lot with breast cancer care before moving into informatics, and always being very upfront and specific about hair loss expectations. Sometimes that can be a very tough conversation, but making sure I'm not trying to sugarcoat it because it will happen, and I don't want patients to be caught off guard by that. So I think for like our nurses and our care coordinators and things out there that are listening, that's something that if that education hasn't happened, they may look to you to provide some of those expectations. Moving down more into like our vinca alkaloids, these I think more of our traditional chemos. So going through like our nausea and vomiting, our bone marrow suppression, our constipation and things like that. Discussing the specifics, like how long do they expect these agents to be given? Is this a really long infusion for vincristine, vinblastine? It's not. It's a quick, usually 10-minute administration. So I do like to set expectations, which might be a very different conversation with like paclitaxel, where the first one may be over 3 hours. So how long are they going to be in the infusion chair for might be an important question to go through and set that expectation for as well. They'd be bringing magazines and other forms of entertainment so they're not just bored in a chair the whole time.
Those are excellent points. I think you brought up some great things. We covered some things earlier, but I think, as you mentioned, there's just a lot to consider, and it's important to always think about your drug first, what the typical side effects are to follow that, and providing your patient and their family and caregivers with the information that they need to, feel prepared and be able to anticipate what to expect and then sort of react and report accordingly. So thank you for summarizing that. Another question we'd like to ask on this series is, how do you see pharmacists and oncology nurses collaborating to help manage the adverse events or toxicities and to provide that patient education as that trusted source for patients who are receiving plant alkaloids?
Yeah, I mean, that's something that working at the Fred Hutch, I've always appreciated, is just our team-based collaboration. My clinical nurse coordinators that I worked with very closely are all kind of our number one go-to for our patients. So I mentioned anything that's happening, any questions you have, reach out to your doctor's nurse here. They know everything. And when they don't know everything, then they know who to reach out to, which is still like kind of their peripheral brain bribe proxy is
right, exactly.
So that's where I get involved, right? They know when they need to get either me or their physician involved to answer these questions. At the end of the day, they were kind of my source of information of these patients. What kind of questions are they having? What should I focus on when I'm going in to discuss these new agents that they'll be starting? Or if they'll come to me when some of these side effects are happening and, hey, Dane, this patient's already been taking their loperamide, but the diarrhea is getting worse. What do you think the next step is? And that's where I'll be like, okay, did you ask like how specifically were they were taking it? Were they just following the OTC instructions? Were they just taking it, just took 2 pills and they said they took it? So I can get a lot of really vital information to know like, okay, how do I make the next step to make sure we take care of this side effect or diarrhea in that case? So honestly, for me at Fred Hutch, it was leaning on them and their expertise and their kind of direct communication with the patient. And then going back to them if I had more questions, and then going to the physician if I felt like that was necessary, just to make sure we had a very collaborative treatment plan in place to help take care of our patients.
Absolutely. And I think what becomes even more evident, not only through this podcast series, but just every day, every newsletter, every email that is talking about a new drug or a new symptom or side effect that's caused by a drug, I think it just continues to highlight the reality that oncology care is becoming too complex for any one person to know it all. And so I think we have to identify our colleagues and our teammates that can be those sources of information and help us collaborate in caring for patients. I think we all bring unique and important skill sets to that team-based approach. And I think our patients are better for it the more that we can collaborate and use, again, each other's expertise to really make sure we're providing the best, most comprehensive care that meets that patient's needs.
Yeah, I totally agree. At the end of the day, it's our team at Fred Hutch that makes our care so amazing, and the things we do for our patients. It's all because of our team-based approach.
So what do you see as the future for these types of agents, plant alkaloids, and their role in the landscape of cancer care?
I could think of this going a couple of different ways. So I already mentioned this kind of when we were talking about alkylating agents in a previous episode, but a lot of these agents can be used in kind of a monoclonal body drug conjugate. So you have like a really toxic plant alkaloid, for example, that maybe we couldn't give therapeutic doses because it would just be too toxic. But if we kind of put that warhead on that monoclonal antibody, maybe we can use one of these more toxic agents that would not have survived clinical trials, but then find really good efficacy with that, while also perhaps limiting the exposure and hopefully reducing the side effects that we see with these agents. Because just like with our alkylating agents, these plant alkaloids are traditional chemotherapy and have lots of side effects that we have to manage. I think some other things that get highlighted, especially in this category, is using different formulations to hopefully avoid some of the side effects. So, for example, paclitaxel, that's helping avoid the hypersensitivity reactions we see with the regular paclitaxel formulation. We're kind of bypassing the issue of solubility in that case. But you can see there's other formulations like the vincristine liposomal, irinotecan liposomal, which have their own pros and cons when we use those in their various disease states.
Well, thank you so much, Dane, for joining us today and providing just great information, wonderful expertise, and really helping us to kind of drill down to the beginnings and how this drug class has evolved over time. As we reach the end of our episode, we always like to close out with a few quick fire questions to help summarize some of our main points. So to start that off, what are some common misconceptions about plant alkaloids?
I think some common misconceptions is that they are just chemotherapy. So we have just our regular run-of-the-mill side effects, so our nausea, vomiting, diarrhea, and bone marrow suppression. But you have to remember a lot of these agents have very agent-specific side effects. So don't just think you know them all just because you know it's a plant alkaloid. Remember and do your due diligence and dive into each drug. Make sure you're aware of some of the specifics like appropriate pre-medication and things like that.
What's something about plant alkaloids that's not often discussed, but you wish people knew more about?
For me, honestly, and what I found the most interesting when I was going back into these agents is just their natural products chemistry origins. I think we take a lot of these agents kind of for granted, but then thinking how, like back when paclitaxel was first discovered, it really was harvested from the bark of the Pacific yew tree, and many of those trees were needed just to get a very small amount of paclitaxel at first. So just understanding that a lot of these agents do have kind of that natural products background, and then appreciating how far science has come to be able to use these as a therapeutic agent. It's pretty mind-blowing for me.
I agree. I'm always fascinated by just the history. So thank you for sharing that. What additional training or education do oncology nurses need to stay current on this topic?
I think with this one, since most of these agents are pretty old and relatively commonly used, I think it's more just remembering what you don't know. So I don't know that it's any special training they need, but it's just like knowing what you do know about these agents and then remembering and being willing to ask questions about specifics that you might not remember, right? Going back and doing that due diligence to make sure you're aware of all the new stuff. There are new stuff that comes around occasionally, like paclitaxel is relatively new. So being willing to dive in and learn some stuff there. And then, of course, if you're ever going to a new institution, it's always good to figure out their hypersensitivity protocols, their extravasation protocols, and things like that, because those can vary from site to site.
And what additional resources for patients do you recommend who want to learn more about these drugs?
I'll probably refer back to same website that I referred to back in the alkylating agent. So that HOPA website has a lot of great information in it. It's in collaboration with ONS. Another awesome example that I'll use is ChemoCare. Certainly that one's a little bit more, I would say, patient friendly. HOPA does a really good job at being patient friendly, but I do still like to highlight those myself and provide some more context when I use those sheets. ChemoCare can be a little bit information overload, so I still like to break out a marker. And then another one that I really, I refer all my friends to, and they have questions. And after I talk with them and whatnot, I might refer them to cancer.gov. They have a great patient-based website where the information's all pretty easily digestible.
Well, that's great. Those are some wonderful options. Thank you again, Dane. It's been great to talk to you again about another one of our interesting drug classes as we work through this podcast series. Do you have any final comments to share with our listeners?
I think I probably shared the same one, but it's no less important, and that's teamwork is what makes the dream work.
I think those are some great words to end on for sure. Thank you again so much for your time today.
Thanks, Jamie. I appreciate being here.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.